Ask a question to the panel.
My question is, why are they not getting any treatment at all while they're incarcerated? They can't go anywhere. It's a perfect time, and it's a waste of time, and they're getting no help at all.
I mean, I could ask him just briefly, because I'm a big advocate, particularly after talking to the superintendent who you have here today. I'm a big proponent, regardless of cost, of having standardized treatment in every correctional facility in the state of New Hampshire, and then have a relationship with the treatment recovery centers after they leave and while they're on parole and probation. It's something I advocate for, and I don't mean to take your time, sir, but I believe it's vitally important moving forward.
Jack, Dr. Wozniak, is this something that's being examined?
Yes, and I think some counties are better than others. I certainly know counties that do provide, they do have licensed alcohol and drug abuse counselors and forensic psychologists in the jail. Not all may. I don't know the case by case, but I'll bet probably half the counties do. And I would actually invite the correctional superintendent to pitch in on that, because look, there are county jails where I'll tell you, I had a mother on the phone. She was calling from South Carolina yesterday, and her daughter is in jail, and she was asking me whether she should bail her out, and I said no. Based on the jail she's in, the best thing you could do is not bail her out, let her stay there, and let her meet with the counseling staff there, and perhaps get established on some behavioral health medication for a mental illness, which could be the first time that's happened in her life. So county jails differ, and some offer better treatment than others.
Well, let's talk about some of the successes that we've seen in individual counties. Joined by David Berry, the superintendent of the DOC out in Sullivan County. Tell us a little bit about the program that has seen a lot of success there.
Sullivan County is a unique program. It's a 90-day plus in-house treatment. People are sentenced through the courts, whether it's at the district court level or superior court level in our county. Very successful. Took a lot of cooperation because it takes buy-in. It took buy-in from probation and parole, takes buy-in from the public defender's office, as well as the judges, the DOC, the delegates who are funding this, the commissioners who support the DOC.
But this is a multi-step process.
It is. It's a big process. They're sentenced through the treatment program. They take drug and alcohol treatment, classes around their addiction. After the 90 days, there's a step-down approach. They continue with their program, but they're in a work release phase at that time. While they're on work release, they're still taking classes at the DOC, and they're still being monitored by DOC personnel. Once they've been successful in work release for 60 days, they are then released to home confinement. They're monitored electronically. At that time, they are still taking classes, still reporting to DOC, and we're still taking part in their recovery. Once they are released totally from our custody and supervision, they are supervised by probation and parole in our county for another 6 to 12 months. So it's a long process, and it's a long commitment. It's not easy time. They're not just going to the Department of Corrections, you know, playing basketball and watching TV. They're committed to a program, and they're programming from 8 a.m. to about 8 p.m.
All right, and recidivism. I mean, some of the other jails we've seen it 60, 70, 80% in some cases. What are we looking at return?
Between 17 and 19%. So our inmates that complete the program come back at a rate between 17 and 19%.
So that is
Very
a successful number indeed. So the question, Dr. Wozniak, I mean, has you reached out to Dave to put him in a room with people at the Valley Street Jail and other areas?
Well, I'll actually be speaking at the New Hampshire Association of Counties annual conference next month. And this is part of the discussion to see who among the counties are willing to perhaps do more than they've done in the past and extend the good work that they're doing now. I want to keep one thing in mind, though. The same state representatives that pass the state budget and do other things and make funding decisions also fund county government. And so if there's one pinch point with respect to funding any program, any outreach, any expansion to respond to this problem, it still comes from your state representatives who have to vote to appropriate the money to fund the sort of programs that Stratford County has done for years.
What does Trails cost Sullivan County?
Trails, again, it's not broken down in terms of the total Trails program itself.
But the county foots the bill.
The county foots the bill entirely.
Yeah.
The budget's $3.6 million annually. We foot the bill. We hire the case managers and clinicians. Again, it's going to take facilities hiring, less correction, not less, but necessarily, but in addition to correctional officers, unique case managers and clinicians and program directors.
I want to bring in Holly Sakala because we're talking about treatment, and you think this is a manageable thing.
So, I mean, first of all, I love the program that's in Sullivan County. I really just applaud them on their efforts. I basically, you said 70% recidivism rate. Do you think that rate could be, significantly lowered if you had a recovery community center with peer engagement while they go through their work release and probation process? Could you see that number really significantly lowered by the community of recovery coming to wrap around them after they leave the program?
Absolutely, because if we could add one thing to our program, that's the missing piece.
So recovery housing,
It is.
recovery community centers, peer work would really exponentially lower that recidivism rate, in your opinion?
Absolutely, because again, once they're released totally after the 8th-month period, once they've gone through the programming, the work release, the home confinement, we have less control about where they're living. And frequently, we're still releasing people with not ideal places to go. We have people that are choosing to stay in work release because they don't have an adequate place to go.
Right.
So that's a huge concern.
I agree with you. We saw 86% of the people engaged in a program such as yours and then utilizing the community supports and recovery housing on the end. 86% of those people did not go back. They didn't go back.
And it's important to recognize that as much as Sullivan County is doing, and other counties, the only catch they have to them is they've been sentenced there, and so they're under the supervision of the Department of Corrections at the county level. But once their sentence is up, they have to let them go. That's where coming into a well-structured recovery support network is critical.
Just to be clear, is that accurate? Once their incarceration is up, is it a voluntary situation, or are they sentenced to complete this program?
They are sentenced to complete the Trails program. Once they are through the Trails program and they've gone through the entire process, then they are supervised by probation and parole for another 6 to 12 months. And that's supervised recovery in terms of treatment. That's not, just showing up once a week and having a urine screening.
Might be a good time to bring in Farnham Center into this discussion. We are talking treatment. We're talking availability of treatment. You have a medical detox. Oh, great. You have a medical detox there at Farnham Center. You also have a residential treatment program and an treatment program, outpatient program, right, Christine?
Care from the most acute in medical detox, short-term, as well as residential, gender-specific, intensive outpatient, and outpatient. We also have a Suboxone clinic. We know with physician prescribing limits, waiting lists are very challenging in New Hampshire. Right now our outpatient census hovers around between 300 and 500 clients, depending on the time of year. In terms of our residential programs, we are almost always full. We do a lot of interfacing with criminal justice, probation, parole, and county jails, as well as the prisons. We applaud drug court efforts. We're also working with veterans courts, justice-involved veterans courts in Nashua, and really trying a multi-pronged approach. We find that the war is not necessarily on the individual, it's on the illness, which is something that I think you spoke really important to. People get well in treatment, they recover in their communities, and that's what we're always looking to expand, is that peer support.
We're hearing that tug of war between not enough beds and outpatient. And there are people in this war that say, we can manage this on an outpatient basis. But you've got some people here who are true believers in the residential program. I wonder if one of the Daves might want to weigh in.
Yes, I would love them to. I would love them to. These are fantastic advocates that have agreed to share their time with us. And I thank you for having this discussion. It's really important.
Just want to introduce yourself, Dave, and give us a little context.
Yep. So my name is David LeClaire, and I was in the 30-day residential program myself. For me, it was, a break from the life that I was living at that time, as I had relapsed in my recovery. So the residential program was crucial for my treatment because it helped stop that behavior at that time. And then while I was there, it helped me figure out some things on my own. Obviously, the help of counselors, but they kind of showed me what I needed for treatment. And so that was very important to me in my recovery, was a 30-day program. For other people, it could be different. As I go forward, I continue with outpatient counseling sessions and continue on with my recovery in particular.
I'd like to get the opinion of Dr. Combe on this. Do you believe, when we're talking, every case is different, do you believe that a heroin addiction can be treated on an outpatient basis?
I'm not an addiction, excuse me, expert, but from both, being on the planet for a fair amount of time and as a healthcare professional, I think that you can control your underlying disease processes over a continuum with the right resources, and I do believe the community needs more of those resources to continue what starts in a particular program. And whether it's, I think that the 80% coming out of that, out of your facility in Sullivan County, I find that to be that's a great number. If you can be 80+% successful, I can speak from patient encounters that I have found there to be discrepancies regarding what takes place once they're out of a facility. And I did get a sense that they were getting services and education while they were incarcerated.
Sure.
The problem was that what takes place thereafter is very hard to manage. And then you're left to your own kind of demons again. You're wrestling with longer periods of time without the touch points that you had with a consistent program. And then you start to find ways to get around it. And then there are less checkpoints, and sometimes they get missed, and then you get further and further away, and the recidivism therefore goes up. So it goes back to recovery in the community being an essential component, but there has to be consistent availability.
Yeah. But again, I mean, we point out the successes of Sullivan County, more or less, that is inpatient treatment. Back to the Farnham Center. Is it a case-by-case basis, or is it a situation where if you didn't have that 30 days where you basically took to get clean, it's not going to work?
I think that's a really common misconception, is that treatment is the same for every individual or every substance of choice, that if you are coming into treatment after struggling with prescribed opiate, either for a motor vehicle accident or an athletic injury, that your treatment is going to be exactly the same as someone who has been using alcohol chronically for years, and that's just not the case. We perform assessments on a daily basis for individuals, or oftentimes we're speaking to family members before the person that's in need of help comes to us, and everyone is different.
On that note, can we hear from the other Dave?
Absolutely.
What is your story? Introduce yourself and yeah.
My name is David Allen. My story was about 7 months ago. I was really struggling with life. I was really depressed. I've been dealing with depression for 6 years. So because of that, it was almost a dual diagnosis for me. I was depressed, so I wanted to use drugs just to get out of that mood. And it took over my life to the point where I needed to do something fast. And so I called the Farnham Center, and within 2 or 3 days they had me in there. And I did the 30-day residential, where all my focus was on getting better for myself. Then after that, I did the outpatient program, and I'm kind of tapered off. But the counseling is great. Like, they specifically focus on what you're dealing with, and I just want people to know that you can have a good life, and if you're dealing with addiction, there is people out there willing to help you. So don't be afraid to reach out for help.
Can I ask a question?
Sure, please.
Regarding Farnham, you handled addictions of all different varieties, is that true?
That's right.
So at any given time with people waiting to come in, you're dealing with a percentage that are coming from, say, the opiate focus that we're talking about. There's methamphetamine without an opiate component, the mental health component, and you're able to work on all of those circumstances.
That's right, yes. We have duly licensed clinicians, and we find that alcohol is a very close second in terms of substance of choice, which we don't hear very often, at least I don't very often in the meetings that I attend.
All right, we're going to continue this